All right, everyone. Today we're going to be going through a new admissions form. This is the ASAM4. Insurance is starting to require this. Certain insurances are requiring it, and we're going to start implementing it. So basically, the main people who need to be trained on this and be ready to use it, especially, are going to be admissions. So it's going to be a technician, whoever's on staff, 2 a.m., middle of the day, doesn't matter. It's going to load with the standard intake paperwork under the admissions tab. Therapists, we need to understand this because this is how we get levels of care and how we're determining detox or residential. And then case managers as well. You're going to need to know this for everything, for intakes, for treatment planning, everything. ASAM, Association of Addiction Medicine, um, they give us this assessment tool to determine what level of care the client is supposed to be at. We've been using a previous version of it, and they just came out with a newer version, I think last year, but now it's being implemented by a couple insurance companies. So that's what this training is for, both for people who you're not familiar with the ASAM at all, and then for those of us who are, but we're getting used to the fourth edition, this new one we're using. So everyone needs to be trained on this, understand the terminology. I really need to know this for peer reviews. Let's say I'm fighting insurance to keep one of our clients in longer. They care a lot about ASAM dimensions, especially the first two. We'll be focusing mostly on those today, and our charting, all the charting for the client and keep who needs to give evidence the client is in detox or residential. So I'll be typing up some of this in a document as well, so you can read through it. But new client comes in. I'm adding all the forms populate. I'm adding the new forms. This is what we're looking at right now. ASAM4 pre-admission assessment. Doing the intake, clients coming through. I've got two of them up here because I've been fooling around with one of them on the test client, but this is the one we're going to be working with now. Imagining I am doing a new one. So here we go. New clients coming in. Let's say it's going to take me 15 minutes to do this pre-screen as I determine what level of care they're going to be at. Okay. Bunch of fancy stuff here. We're going to keep going. All right, dimension one. So we have 6 dimensions. Dimension one, intoxication, withdrawal, and addiction medications. Basically, this is withdrawal potential. How severe is the client's addiction? Is it to the point where they're physically dependent on the chemical? So, opiates, big dependency factor. Alcohol, big dependency factor. And of course, probably the biggest one's going to be benzos, Valium, things like that. Of course, kratom, tramadol, there's other meds that will develop dependency. Even for meth and cannabis, there's going to be still some dependency factor there, but definitely the big ones are going to be the opiates and the alcohol. Help us extend care. Y'all might have noticed that sometimes for cocaine, for meth, for amphetamines, Adderall, things like that, clients have to move through detox straight to residential. Sometimes we won't get any detox for them. So especially for opiates and alcohol, this one's really going to apply. Uh, Level 4, hospital emergency room setting. If they're coming in and they're having a seizure right in front of us, clearly that's not what our facility is designed for. 911, paramedics need to take them to the emergency room. We should not get clients like this. How do they even get to our facility? That's going to be crazy. So that really shouldn't happen. Level 4. 3.7 and 3.5. 3.7 and 3.5 is really what we're built for. As the client's coming in for intake, it's going to be kind of weird, guys, if they're lower than a 3.7 in a lot of these dimensions. This basically just means detox and residential level of care. That's really what it means. So right here, the only difference with these as you're coming in is you're going to understand with the client, you're going to ask them, are they using intravenous? Are they using IV medications? Do we need to help them with that? Semaglutide, right? The GLP-1 inhibitors, the weight loss things. Diabetes is probably a big one. Testosterone injections, that's another big one. Invega, right? So that's the antipsychotic sometimes for schizophrenia, mood stabilizers for bipolar. Maybe they're taking an IV for that. Please ask them about that, guys. Ethically, we need to know because we're going to help them. We'll communicate that to the doctor. But also, it really helps with keeping them in our care because that's rough. Even insurance knows that staying on top of those meds, that level of serious medications, someone might need 24-hour support to get in that, especially while they're sick, detoxing. So let's say a client comes in, probably the majority of them are going to be no IV meds. I'm going to click 3.7 if I think they're having withdrawal symptoms, okay? withdrawal and associated risks. So that's intoxicated and associated risks, withdrawal. All right. So what kind of withdrawal the patient is experiencing or anticipated to experience? Let's say they're coming in loaded very, very frequently. They're coming in completely loaded. They're not kicking yet. I anticipate they're going to experience moderate to severe withdrawal symptoms. Opiates, gastrointestinal diarrhea, pyrolection, whatever that's called. You know, the nerve pain, the feverish pain for nerve endings, chronic fatigue, headaches, migraines, insomnia. That's going to be across the board for all of the drugs that they're taking. That's going to be a problem. And then the opposite of that, hypersomnia, oversleeping, maybe for methamphetamine, cocaine, things like that coming off of that. Lack of appetite, can't sit still, physical agitation, cold sweats, alcohol. All right, so alcohol and benzos, threat of seizures, tremors, the high level ones, delirium tremens. That's where we might be seeing shadow people when we're coming off these. You know, you're seeing movement in the corners of your vision. Delirium tremens, very, very serious. Uh, Memory loss, swollen brain, wet brain, Wernicke's encephalopathy or something. If you guys want to look that up, I always mess up that second word, but that's a swelling of the brain due to alcohol consumption. If you notice a client that seems not quite all there, that is a detox symptom, and sometimes it could be permanent. It's a scarring and a swelling in the brain. So again, if you guys come in, could be controlled with this level of care and patient is not a risk to self-drivers, and you click 2.7, just be prepared. We're probably not a good fit for them. Insurance is going to bump them down to outpatient. They're going to say, yeah, they might be a little uncomfortable, but they definitely don't need 24-hour supervision, right? They don't need that level of care. So please, guys, just remember our level of care is 3.7. If you have a client intaking and you don't think they meet withdrawal issues, that they're not going to have withdrawal issues, please contact me immediately, or Carrie, or Teresa, and let us know that they're not a good fit for us. Again, it's going to be weird that they showed up to our facility if they weren't using drugs that day or the day before or something like that. How did they get to us? Like, we're a detox in a residential facility, but I don't know, maybe crazy stuff could happen. So 3.7, we're focused on that, 3.7 and 3.5. Addiction medication, daily medical management and nursing care, including after hours. So they have a big focus. That's one of the new things with the ASAM4 for addiction medication. So that's going to be Vivitrol, naltrexone, buprenorphine, Subutex, right? I think a lot of y'all are familiar. If you're not familiar with that, please Google it and then go ahead and ask other staff who are familiar, or I can do training on those. Even sometimes Wellbutrin, doctors might use Wellbutrin off label for methamphetamine and cocaine addiction. And abuse, that's the old school. Camprol, that's another old school alcohol craving reducer. So 100% of our clients, guys, 3.7, they're coming in for addiction treatment for detox and res. I want them to see the psychiatrist and talk about medications that might help them with their sobriety. So 3.7, it'd be weird if 100% of the time that's not clicked. Again, we're going to refer all of them to be assessed by the doctor. Okay. So always let me know if for some reason you don't think the client will benefit from addiction meds, addiction reducing meds. All right, so that's the first dimension, guys. For us, for a detox residential facility, insurance really, really cares about that, and they should. It makes sense. They're coming to us for withdrawal issues, so they're going to focus on that a lot, and they always ask me about that. Last date of use, cravings, withdrawal issues, detox issues. They ask me every time I speak to insurance about those things. Next one is going to be biomedical, just medical issues. So these can absolutely be because of the drugs and alcohol, or they can be outside issues. They can be medical problems correlating to that. So chronic pain, diabetes, HIV, STDs, hepatitis C. Those are some common ones. Low testosterone, hormone issues, allergies. All right, the two that we might not ask clients, right? So I'm sitting with a client and I say, "Hey, do you have any medical issues?" No, I'm perfectly healthy. I'm going to be sitting here, "Oh man, you've been homeless for the last year or two, and you're not working. You definitely haven't been eating well, and you've been putting street drugs into your body, or you're drinking every single day. Physically healthy, I'm screwing up if I don't ask more questions. So I'm not going to take the client's word for, oh, I'm fine. I have no issues. Because the baseline for them might be 9 out of 10 pain. Physical agony is just a regular Tuesday afternoon. They're just used to being in agonizing pain all the time. So I'm going to ask more questions. Two big ones that clients don't think about that are really highly correlated with addiction, just in my experience, is history of head trauma, CTE. A lot of ex-football players who get caught up in drugs and alcohol, they do brain scans later and find out those getting knocked out and those concussions might be a driving factor. Almost 100% for sure they are with addiction and with other behavioral issues. And dental pain, right? So their teeth, almost 100% of clients, you ask them about that, and they'll say, yeah, maybe part of the reason I'm not sleeping, part of the reason I have anger issues, part of the reason I have anxiety issues is because I am in agony, dental pain every moment of the day. There you go. They might not even think of those things, but we're going to ask them. So again, if they're lower than a 3.7, guys, so this is the same thing as before with IVs, no IVs. If they're lower than 3.7, please contact us. That is either the client is weirdly in perfect health, I don't know, or we're not asking enough questions. That's our fault, and that's okay. We just need to train more and learn to ask the right questions. So no IV meds, that'll be for a lot of our clients, but some of them, again, testosterone, like that's becoming more and more common, the injectable versions of that. God willing, hopefully, maybe someone with schizophrenia is on an injectable that works for them and they already know they're taking it and they need a prescription. So you might click that one if they have something like that. Pregnancy related concerns, again, gender specific, and you'll ask them all about that. But risk rating 0 will be for, whatever, 99 out of 100 clients. But we will have clients who are pregnant, and that's a big deal. Helps us work with them longer, and we can really do amazing work, especially case management wise. Psychiatric and cognitive conditions, guys, I just view this one as mental health. Just view this one as mental health. That's really what it's talking about. Co-occurring, they're in addiction. What is the severity of their mental health concerns? The truth is, guys, addiction does not exist on its own. Maybe like 1 out of every 1,000 people with addiction issues might be like no psychological issues. They got physically dependent because they had a car crash and they were stuck in the hospital and dilaudid for like a month and they're physically dependent, but they don't really have a mental health issue. Those people aren't going to show up to us. That's not going to be the right client. Psychiatric and cognitive conditions, mental health conditions, 100% of our clients. And this is going to be asking about the severity there. So let's, again, 4 is emergency room. This is suicide and homicide. The client sitting in front of you saying, I am going to kill myself as soon as I leave this office, and I'm going to do it with a specific means. I'm going to do it with a gun. 911, crisis assessment team, done. They're not a good fit for us. Maybe they'll do a 72-hour 5150, come back. That will happen. No issues. We're going to be waiting for them. We'll have a bed ready. It's all good. Or I'm going to kill someone else, obviously. Not thoughts, plan and means, right? A lot of our clients might have suicidal, unfortunately, passive suicidal thoughts. That's going to fit them into 3.7. And our therapist and our case management team are going to be prepared for that. So that's okay. So 3.7 and 3.5 are going to be the two. So let's read through this. 3.7, the patient requires active psychiatric management after hours due to exacerbated symptoms or insufficient support for addiction treatment, or would otherwise meet criteria for level 5 in LOCUS. So LOCUS, that's the scoring for a mental health primary program. That's not an addiction focused program. So it has a severity scale there. So this is talking about why does a client need more than 9 to 5 services, right? So in PHP or IOP, they'll get access to case management and medical care during business hours. They're saying why overnight? Like why does a patient need to be supported overnight? Insomnia, first one. Boom. Insomnia. And I hope you guys have noticed the sleep issues have shown up in dimension 1, dimension 2, and now they're showing up again in dimension 3. Oh my goodness. That is insidious, a major, major issue. Diet. The client's mental health is such an issue that maybe they'll struggle with binge eating, or maybe they'll struggle with not eating. Those are called not eating is ADLs, activities of daily living. They're not able to take care of themselves. Anxiety, panic attacks are debilitating. And if they don't have staff there to sometimes just sit with them, sometimes, y'all are in the office late at night and a client comes in and they just need you to sit with them while I have a panic attack. Otherwise, they would be alone. They'd be alone in an apartment or in a sober living with peers who don't understand how to help them, and they might not be a good fit. So, depression, the client will not get out of bed without prompting. They'll stay in bed all day long, and their life will not progress without support. Of course, suicidal ideation, insurance, they care a lot about that. Again, if it's more than passive, we're going to go transfer them if they have a plan and means, and we'll welcome them back. But please, we're constantly annoying clients by asking them about suicidality because it really matters. Um, Bipolar, schizophrenia, these are medication first treatments. Let's say the client's mental health is on a level where I'm not confident they can go to CVS to get their prescriptions filled. I'm not confident that they're going to do that like in Vega, Abilify, like injectable meds, that they're going to stay on top of that, going to psychiatric appointments and taking care of themselves. I'm not confident they're going to get their naltrexone, their Vivitrol, their opioid blockers, their MAT meds. I'm not confident they're going to be able to do that without more support, more education, more routine building. And they're going to really struggle and probably relapse as soon as they leave care. So again, 3.7, 3.5, the patient requires intensive mental health. So this one is active psychiatric management. This one's intensive mental health interventions, residential support for monitoring and response to mental health concerns with stable med management. Super close to each other, everyone. But of course, 3.5 is going to be a lower severity than 3.7. 3.7 is more of a detox. It says residential here, but it's a detox level. And this one is going to be fitting a little bit closer into PHP and RTC residential. So you make the determination on how severe, and that's up to you. Persistent disability. The patient's baseline impairments necessitate a more flexible treatment environment with increased staff support and specialized training to address mental health symptoms or disabilities compared to standard care. So again, minimum level 1.5, 100% of our clients are probably going to be there because the mental health component is probably the thing that's driving their addiction. So standard care is going to be you and I, like going to see an outpatient therapist, an hour a week, 2 hours a week. Clearly, that's not what's going to work for the client because they're showing up at our door. Dimension 4, substance use related risks. So this is relapse proneness. It used to be called relapse proneness. This is for relapse prevention. Again, 3.5. Why are they showing up to us? That's weird if they have no problem with relapse proneness. I don't really know how else to train you guys on this one, but if you feel like the client has no problem staying sober and they're showing up at detox, what's their story? I'm fascinated to hear it because that's weird how they showed up to us. This is environmental. So risky behaviors. This could be unemployment. This could be domestic violence. This could be drug using friends and family. This could be the bar that they hang out at down the street all the time. This could be watching Euphoria, right? Watching shows that really glorify drug use and stuff, and they're really into that. That's a substance use related risk. That's a substance use related behavior. The client is probably going to say, yeah, most of my friends use drugs, or I have no friends, right? That's risky behavior. I'm alone. Dimension 5, recovery, environment, interactions. Again, social stuff. Guys, this is really where we might start thinking a little bit more about employment. So if they're unemployed, 3.5, boom, we're done. They are 3.5. Unemployment means they can't provide food, and shelter for themselves. Like done. That's 100%. They have to be employed. That is the number one factor that leads to success in recovery is employment. I'd like it to be 12 steps, or I'd like it to be EMDR or something fancy, but the truth is people really need to work for a lot of reasons. And it definitely is the biggest thing for sobriety. Unemployment, homelessness, those are going to be the two ones. Homelessness, guys, counts. Couch surfing with friends. I have a car and I sleep in my car. Those are both homeless. I've been in residential treatment for the past year, relapsing and going from treatment center to treatment center. That's not a home, that's homelessness. Um, so just remember those things. If the client says, "Oh yeah, I have a place to stay," and you ask them and they say, "My drug dealer has a couch I've been crashing on." I don't care how long they've been doing that. They don't have a home. That's homelessness. If they're coming from jail, uh, yeah, technically they have a roof over their head, but that's not a home. They're homeless. Unemployment, homelessness, pretty much 100% of our clients are going to struggle with one of those things. So they're going to be 3.5. But of course, other things could be domestic violence. Guys, we're not a 12-step program, but we do highly encourage that, right? That's a really big deal. Just if maybe I don't know everyone's personal story, but even if you personally don't believe in 12 steps, just the social component and the access of a program like that is amazing. Not having a home group, that's a meeting that you don't miss for anything that happens once a week. Not having a sponsor, an actual sponsor, and not having a commitment. So that's a literature person, chairperson, things like that. Those are a big deal. And insurance even thinks it's a big deal. They ask me about that. Those three things, they actually ask me about those things to help determine level of care. That kind of shows how amazing, how really helpful AA can be and NA can be. So if they don't have those things, 3.5, man. Safety or well-being, guys. Just remember safety or well-being. Yeah, there might not be a panther. They're not living in a jungle where panther's going to kill them, but safety. I've got a roommate who drinks still, and there's going to be alcohol in my home. That is dangerous, right? So that's going to be, again, no specific needs, guys. That's a big deal if you think they're showing up to detox and their home environment is completely safe. Maybe there is no drugs and alcohol in their home environment, but if they're living alone, guys, again, that is unsafe. Alone, 0%. We don't want that for clients in early recovery. That's dangerous. Um, the patient's present environment jeopardizes their safety or well-being, requiring secure housing with adequate support to ensure their safe participation in outpatient treatment. So why are we housing the client? Why can't they do all of this stuff that you're going to do for them and just come in from home? Maybe they have transportation issues. Maybe they're going to relapse right away. Recommended assessments, guys. I want you to click these each time the same way. So we do CWAS and COWS. These are our rounds. Dimension 2, I'm still trying to figure this out, guys, what we're going to do for Dimension 2. This is really for our medical team, but I want you to leave that blank for right now. Dimension 3, we do the PHQ-9, we do the GAD-7, and we do the Columbia suicide screening. We do BAM and BAM, brief addiction monitor for both of these. And Dimension 6, I want you to leave this one alone. Oh, I'm sorry, this one's prepare. That's what we're doing, prepare. After all of this, where do you think the client should be? 9 times out of 10, 99 times out of 100, it's going to be 3.7. And if it's not, please let me know. If it's 3.5, guys, we can still get res, or 3.1, we can still get residential for them. But for our clients meeting 3.7, guys, sometimes they're only letting us work with them for a week or two. So again, if they're lower than that, I want you to imagine how difficult it is going to be for us to get work done with them. If even at 3.7, we struggle to get any type of time with the clients. Patients' preferred level of care. I mean, they're coming into detox. Clearly, you're not going to be talking about levels of care with them like this, but they're coming in requesting detox. You know, they want to, the main reason they're probably coming in is because they want to talk to the doctor about helping them with comfort meds. That's 3.7. Recommendations. Just repeat it. Intake client at 3.7 level of care. Date, detox, update, sign and submit. Client signature, then your signature, then my signature. Client signature. And then the thing we struggle with sometimes, guys, is you have to sign it afterwards. The staff who's completing it, I need your signature. Otherwise, it's just going to say in progress. And then I'll say ready to review. And then that's my responsibility to get it signed. And it needs to be done the day of, guys. Worst case scenario, within a 24-hour window. My signature needs to be on it within a 24-hour window. So that's it, guys. That's the ASAM4. 15 minutes or so. Hopefully this presentation wasn't too boring for you, and hopefully you learned a little something from it. This one's important, guys. Practice makes it faster. So once you've done this once or twice, maybe even role play it with one another while you're on shift. I'd be willing to set up meetings for you guys if you ever need more conversations. We can set up a face-to-face training and we can do it that way. But please get comfortable with it. Look over these over and over again. You will have to do this eventually. Even therapists, case managers, all of us, we're going to have to do this eventually, and we need to know this language. So please get used to it and come up with any questions you have. Email me, and that's it. Okay. Thank you, guys.